We're going to change topics now. We're going to talk about depression. Now, what you need to know about depression, and this is tested on the NCLEX RN exam, are the symptoms of depression, the medications, and you also need to be aware of suicide prevention. Depression is a mood disorder, and the three different types of depression are listed here. The first is a major depression, and if a client is experiencing a major depression, these symptoms many times interfere with their personal lives. The second type of depression is called dysthymia, and this is chronic depressive syndrome. The person with dysthymia doesn't necessarily enjoy life. You know, they're always sad, but they say to you, I've always been this way. The last is bipolar illness, the depression that goes with that, and we're going to talk about that in a few minutes. When you're dealing with a depressed patient, there are some signs and symptoms that you're going to see. First of all, the client has changes in self-esteem or self-confidence. They have low self-esteem. They have feelings of helplessness and hopelessness. Perhaps they have obsessive thoughts and fears or excessive worrying. You're also going to see changes in self-care. For example, a person who was normally well-groomed now becomes more unkempt with their appearance. Perhaps the person lacks energy. The person may experience insomnia, where they have difficulty sleeping, or hypersomnia, where they just want to sleep 20 hours a day. They may experience weight loss due to anorexia, or the opposite may happen. They may have weight gain and constipation. One of the biggest changes you're going to see is the change in mental functioning. Clients who are depressed have a decreased attention span. They have decreased concentration. They have slowed speech and thought processes. A person who works a lot in a psychiatric unit once said to me that patients who are depressed, they're thinking like this. So everything is very slowed. Now, because of the slowed thinking, there also, what you'll see is ambivalence and perhaps indecisive behavior because they have difficulty making a decision. Now, if you are dealing with a client who is depressed, you always need to be concerned about the safety issues. You know, what is the suicide or the homicide potential? You would ask questions like, when you feel depressed, what thoughts are going through your head? You said you feel depressed, tell me what it feels like, because you want to make sure, you know, that the client isn't thinking about harming themselves. Now, when you are caring for the client who is depressed, first and foremost, be alert for self-destructive behaviors. It's very important that you not only assess for these things, but you report all behavioral changes to the team, especially an increase in energy or agitation, because you know that this is many times when the person, you know, the antidepressants kick in and they have more energy, is when they now have the energy to carry out a suicide. If a client is having a psychotic depression, it's important that you find out what the voices are telling the patient to do. Are they telling them to hurt themselves and others? It's important that you meet the physical needs of your client. Because they're anorexic, they may not want to eat at all and simply won't eat and start losing weight. So you're going to offer them small, frequent feedings of their favorite foods. It's important that you make the surroundings pleasant and you offer companionship. You wouldn't give somebody their food and then just simply walk away. You would sit there with them while they're eating. Important to encourage fluids also. Now, with your client who is depressed, remember, they may have the insomnia or they may have the hypersomnia. If the person has insomnia, they're not sleeping well, what you want to do is offer them rest periods after activity so they don't get terribly fatigued. If you have the client who has hypersomnia, all they want to do is just stay in bed with the covers over their head, you need to make sure and get them up and get them dressed. make sure there's a routine to their day. For the client who has insomnia, you want to work out a bedtime routine. The back rubs, a warm bath, make sure they don't have caffeinated drinks in the evening, soft music. It's important that you decrease the client's anxiety, and the main way we do it is through the psychopharmacology. So again, review your anti-anxiety medications. Another way that you're going to decrease the client's anxiety is not give them too many choices, because they're thinking slowly and they'll feel too inadequate to make decisions. It's important that you provide structure, be brief, be simple. You want to support the client's self-esteem, and you do this through a warm, supportive environment. Now remember, the client's thinking very slowly, and it's very painful for the nurse to sit there quietly and wait for somebody to get their thoughts out. But that's what you're going to do. You're going to take all the time you need to allow the patient to express themselves. You want to be consistent. You want to be predictable. To decrease social withdrawal, you want to introduce the client to other patients when they're ready, encourage them to participate in therapy. Also, to support their self-esteem, you need to give them tasks that they can be successful at. So, if you have a client who is depressed, this isn't the person you're going to sit them down to a 1,000-piece puzzle and say, okay, I think you need to work this. You're going to, more simple arts and crafts, perhaps cooking would be a good activity, because it's something that could be done successfully within a short period of time, and the person can feel good about what they have accomplished. Now, one of the treatments for depression is electroconvulsive therapy, or ECT, and this is a topic that is on the NCLEX exam. It's important that you know that due to the ECT, or electroconvulsive therapy, the client will have seizures or convulsions that are similar to grand mal seizures. Patients who they use this course of treatment, they'll have a course of 6 to 12 treatments given 2 to 3 times a week. You need to inform your client that they may have short-term memory loss after the seizures, that it's going to happen to them and it's expected, it's normal. This is a procedure that requires informed consent, so you need to ensure that it has been signed and attached to the chart. The client will be NPO, make sure and remove dentures if they have them. You will administer muscle relaxants and atropine to dry secretions. Make sure that you have oxygen and suction equipment available. It's very important after the procedure that you orient the client frequently, because they're going to be very confused and disoriented after the seizure. So stay with them, frequently orient them, and also take their vital signs. Now, in addition to electroconvulsive therapy to treat depression, obviously clients are going to be given antidepressants and anti-anxieties. So make sure in your course book that you review the antidepressants and anti-anxieties. Now, let's talk about suicide, and what you need to know, or what might be tested on the exam, are what are the symptoms or indications that a person's thinking about suicide. What are predisposing factors, and how are you going to intervene with an actual suicide attempt? Now, suicide is the act of one taking their own life, and usually this act is accompanied by feelings of intense pain and hopelessness. These people, a person who commits suicide doesn't want to die. They just simply don't know any other answer to the pain and the hopelessness they're feeling. They want to get rid of those feelings. Now, you're going to see changes in behavior, perhaps. And remember, we talked about earlier, if a client is on antidepressant medications, and after they've been on their medications about 10 or 14 days, after taking the antidepressants, they now have increased energy. So you'll see the changes in behavior or mood. Perhaps the client gives away possessions, or they withdraw from activities. You always want to be assessing for the presence of weapons, razors, or pills. Or perhaps the client leaves a note. You need to be listening very carefully to your clients. They may make overt statements like, I can't take this anymore, or covert statements, things are just not going to work out for me. When you're assessing the client, you always want to be concerned about the lethality of the suicide plan. So if somebody's talking about committing suicide, you want to find out what is their method. If you have a client who says, I'm going to shoot myself, the next logical question is, do you have access to a gun? Yes, I do. Now, that's a lethal plan. They have a plan, they know how they want to do it, and they have a way of doing it. If you have a person who says, I'm going to kill myself, well, how are you going to do this? Well, I think I'm going to take pills. Do you have access to pills? Well, no. That would be a less lethal plan. So be aware of the lethality. As far as the predisposing factors for suicide, males over the age of 50, also the age group 15 to 19-year-olds is a predisposing factor, as well as a person with poor social attachments, a personality disorder, or overwhelming precipitating events. Suicide by firearms is the most common method of suicide in the United States. And the highest rate of suicide in the U.S. is white men over the age of 85. When you're caring for your client, don't be shy about discussing the potential for suicide. We're always afraid this is going to give somebody ideas. No, it's not. And many times the client is absolutely relieved to be able to talk about the event. So you want to ask some direct questions when you are suspicious that a client is thinking about suicide. It is important that you remove all potentially dangerous items. You want to work on increasing the client's self-worth by providing a strong therapeutic relationship. You want to increase the client's confidence by letting them know that you are there and you are not going to let them hurt themselves. If the client is in the psychiatric unit, they'll be placed on a one-to-one observation. And what this means is that this client will be in view of a staff member at all times, and the distance is 1 arm's length. So somebody is essentially with them at all times. Now, if you have a client who's on a one-to-one observation, you must chart every 15 minutes their behavior, their mood, and verbatim statements that they have made. It's important that you give the client a sense of control other than suicide, that there are other ways to deal with the problems. So you will develop and use a suicide contract. It's important that you assist the client with problem solving and decision making. These guys aren't thinking clearly, and what you want to do is use their ambivalence about committing suicide as a way to help them redirect and rethink. You want to talk about positive alternatives that may give the client hope for the future. If a client is, you walk in and they are trying to commit suicide, you need to intervene quickly and calmly. You're going to first and foremost remove all harmful objects. Stay with the client. Because what you want to convey to the client is, I am not going to let you hurt yourself. I care too much about you to let this happen. Reassure the client that you're there to help them and avoid all judgmental remarks. The UCLA Suicide Prevention says that you need to convey to the client, the crisis is temporary, unbearable pain can be survived, help is available, and you are not alone. Hi, I'm Barbara Irwin. Welcome back to Psychosocial Integrity. We're going to begin this part of the segment by talking about situational role changes. Situational role changes are critical life problems because they're commonly encountered by most people. It's situations such as death, divorce, separation, illness or injury, job loss or retirement, marriage or a new baby, perhaps the empty nest where the last child leaves from home, or a spouse begins or ends full-time employment. Now, how a person reacts to these situational role changes is determined by learned coping behaviors. So the significance of the event, is it a positive or a negative? The amount of control that the person feels over the change, the number of changes the person has experienced over a lifetime, and the positive or negative resolution of the previous changes. So because of all these things, the situational role change may or may not become a crisis. Now, when you're dealing with a client undergoing situational role changes and they are feeling like it is a crisis, you're going to use crisis intervention. You're going to determine what was helpful in the past. You're going to establish a routine, or not you, but you're going to encourage the client to establish a routine. You're going to encourage the client to exercise regularly. Humor is one of those mature defense mechanisms. So you're going to encourage the client to not see everything as doom and gloom, but see the humor in the situation. Encourage the client to eat regular meals and good nutrition. Don't go after that gallon of ice cream. And also you're going to teach them relaxation techniques. Now, situational role changes can cause stress, and that's what we're going to talk about now, is stress. And as you all know, there are a lot of things in life that causes each of us stress. Stress is defined as demands that are put on the body. These demands can be physical, such as trauma, infection, hunger, excessive cold, heat, or pain, or they can be psychosocial, such as the loss of a job, death, retirement, or even marriage can, certainly cause stress. Now, positive responses to stress include problem solving, reaching out to others who care about us, because that certainly can be helpful. Also redefining the situation to not just see the negatives, but see positives in the situation also, and how we can use the situation to our advantage. Now, clients who are having a negative response to stress, they use avoidance, they refuse to deal with the situation. Perhaps they blame themselves. If I just sit and blame myself because something is happening, that prevents positive action toward a resolution, or they may use wishful thinking. I just hope that all resolves on its own. Indications of stress include headache, sleep disturbances, restlessness, GI upset, frequent urination, palpitations, and crying. Now, common stressors in everyday life include family. I mean, we all know that because we're all part of a family. Perhaps the job is a stressor, as is the lifestyle we've chosen, body image changes, or the situational role changes that we just discussed. Now, I think the nurse is in a wonderful position to help the clients in stressful situations. First of all, clients who are ill are, in a stressful situation. It's important that we determine exactly what the client sees as stressful and then identify how stressful it is for the client, or the level of stress. As with any crisis intervention, we want to determine how the client has dealt with stress in the past. And we just want to provide high-quality support and information so that we're able to enhance the client's sense of control and self-esteem. Now, specific implementations include providing support and information to the client, maintaining the client's independence, or helping the client maintain their independence. We want to find out what previous coping strategies were for them. Allow the client to make choices, because they're the ones that need to work through this stress. It's important that we also perhaps might teach the client biofeedback or meditation. In addition to the biofeedback and meditation, we may instruct the client regarding relaxation techniques. The meditation is filling one's mind with just one thought. Guided imagery is something else we may teach the client, which is to think about peaceful scenes that involve total relaxation. Breathing exercises are also very useful, as is progressive muscle relaxation. I'd like to talk now about sudden infant death syndrome, or SIDS. SIDS is thought to occur because of a brainstem abnormality in the neurological regulation of the cardiorespiratory control. So what happens is this will be death of an infant during the first year of life. It occurs many times between the hours of midnight and 9 a.m., and there is an increased incidence in the winter. It is usually the mother that finds the infant. Sudden infant death syndrome, or SIDS, occurs more frequently if the infant has had documented life-threatening events. There was a sibling in the family with SIDS, a preterm infant with pathological apnea, black infants, multiple births, infants of addicted mothers, or infants who have been put to bed to sleep on their abdomen. Now, the most important focus we want on sudden infant death syndrome is, of course, the prevention. Since the Back to Sleep campaign that began in 1992, the incidence of SIDS in the United States has decreased by 40%. So that is certainly significant. For the children who had apnea, or the infants that had apnea in the hospital, they may use a home apnea monitor. So this is useful for children or infants who were diagnosed with central hypoventilation, and the preterm infants who continue to have apnea at the time of discharge. It's very, very important that you instruct your parents to place their infants in a supine position or on their backs to sleep, which is why the Back to Sleep campaign. If SIDS occurs, be supportive of the parents and the family, because the first response is going to be that they're responsible for their infant's death. If they had only done something different, it wouldn't have happened. It's very important that if you are the initial person in, that you allow the parents time to say goodbye to their infant. And you want to encourage continued follow-up care with healthcare professionals and refer the family to the SIDS Foundation. Okay, we're going to talk now about psychosocial adaptation. We're going to be talking about some other issues in psychosocial integrity. And the first is counseling techniques. You're certainly going to use these counseling techniques. They can be used in any setting in nursing, but they're certainly important if you're working in a psychiatric unit. So we're just going to talk about some different counseling techniques that you may engage in. The first is confrontation, and this calls attention to the discrepancies in a client's communication. The nurse addresses an issue that the client is avoiding, minimizing, or simply doesn't want to accept. For example, the client who made a suicidal gesture but says it really wasn't serious. That would be a situation in which the nurse would gently confront the client. Another counseling technique is contracting, and this structures the nurse-client relationship. The nurse and the patient establish expected behaviors, goals, rules, and consequences that they're both going to abide by. Now, contracting emphasizes the client's participation and responsibility, and the act of contracting enables the nurse to do something with the client, not for the client. Another counseling technique is focusing, and this helps the client identify problems and determine their relative importance. So by focusing on specific issues, you create order, guidelines, and priorities. For example, you might ask a question that says, "Tell me about the relationship with your wife." And based on that, then you might focus on specific concerns that the client may have. Another counseling technique is interpreting, which is is exploring the possible explanation for feelings. Another technique is making connections. You help the client connect seemingly isolated phenomena by filling in the blank and establishing the relationship between events or feelings. Modeling is to exemplify through actions and verbalization the behaviors the client is working toward. For example, maybe you have a client that avoids conflict because they've never learned how to do conflict resolution. So the nurse will model for the patient conflict resolution with a colleague. Another counseling technique is to provide free feedback. So you provide constructive information about how the client is perceived. So through this feedback, the client can confirm that the nurse's perception is correct or the nurse's perceptions are correct. Reframing is another counseling technique, and this is looking at an issue through a different perspective by using different examples or different descriptions. For example, maybe a student has given a speech and they really did terribly on the speech, and they said, "This is the worst thing I've ever done. I can't give speeches." Okay, perhaps the first speech wasn't as successful as you wanted to. What did you do right? And what do you need to improve? So that kind of reframes the conversation. Another counseling technique is stating observations. You describe what is happening in the nurse-client relationship and how it has relevance to something that's going on in the client's life. Another counseling technique is summarizing, which gives feedback about the general substance of an interpersonal exchange. And the nurse summarizes with the client at the end of the exchange. And by summarizing, the nurse is able to pull together related ideas and also restate suggestions. Now, it's very important when you're counseling your clients that the nurse should follow these guidelines. The first is congruence or genuineness. We want the client to know we're interested. We don't want to say to them, "I'm interested in you," as we're acting completely disinterested. So we need to be genuine. We also need to be empathetic, and that is that we see things from the client's perspective. Now, it's not being sympathetic, but empathetic. The last guideline that the nurse has to follow is that of respect. We always respect our client. Let's talk for just a moment about the religious and spiritual influences on health. If you're caring for your client holistically, you must be able to support their religious and spiritual beliefs. Now, you know that religion is a basic human need that must be satisfied in order for a client's well-being. Religion may provide explanation for illness, misfortune, or it can also prevent illness and misfortune. Religion can also be used as a basis for behaviors and also for healthcare decisions. Now, I think when you're dealing with a client's religious and spiritual beliefs, you have to respect them. You have to be aware of your own, but you also have to be aware of theirs, and your job is to support their beliefs. Some influences that you may see is a client wears amulets or charms or certain clothing or jewelry, or perhaps carries a talisman or a good luck charm. Some people drink or eat certain tonics or foods. Perhaps somebody performs or they don't perform a certain activity at a certain time, or perhaps they participate in religious activities. So what you're going to do when you're supporting the client's religious and spiritual beliefs is, as we said earlier, you need to be aware of your own spirituality and your beliefs, and don't impose your beliefs on the client. It's important that you obtain knowledge about the client's religious practices, that you be respectful and sensitive to their beliefs, and also that you observe their verbal and nonverbal behavior about their beliefs, because this can indicate to you spiritual distress, and that is certainly something that you would want to follow through with. Okay, we're going to talk about psychopathology now. Let's talk about caring for the client who is induced. Why are clients induced? Well, first of all, they're induced because they have cephalopelvic disproportion. You know, the baby's simply too large to get through the opening. So you're not going to induce somebody who does have CPD, because there'd be no reason to induce labor and then turn around and section the lady. Also, there must be a mature vertex presentation. So if the baby's breech, you wouldn't want to induce because you don't have a good presenting part there that will cause the cervix to dilate. The head has to be engaged, and the cervix has to be ripe. Now remember, we talked about early on in our talk today that the cervix is hard, and if the cervix continues to be hard, it hasn't softened, you can induce the lady. She can have all sorts of contractions, but she will not dilate, so therefore there's no reason to do it. Other indications for induction is diabetes. If you've got a baby that's really large, if you have a baby that's post-maturity, past 42 weeks gestation, client with pregnancy-induced hypertension, because remember, the only cure for pregnancy-induced hypertension is to deliver the baby. Another indication is if you have a baby who is in trouble, and also logistical factors. The woman who says in history, for my first baby, well, I thought I was in labor and the hospital's 30 minutes away and I didn't make it. Well, that person you're going to go ahead and induce, so they will be in the hospital when they deliver. As far as implementation during an induction of labor, you're certainly going to monitor your baby very carefully, and if you see any of the non-reassuring fetal heart tone patterns, then the induction is going to stop. Monitor the mother's vital signs, especially her heart rate and blood pressure. Also monitor the progress of the labor. If the client's not progressing, the cervix isn't dilating, then there's really no reason to continue the induction. You might prepare the client for an amniotomy, which is where they rupture the membranes. Then you begin the Pitocin administration by a pump. This is always given piggyback through a pump. It's never the main IV line. You're also going to monitor your contractions very carefully. So your contractions should be 2 to 3 minutes apart for less than 90 seconds. If you identify fetal distress, or if the contractions are longer than 90 seconds, then you're going to stop the induction. Because if a contraction is every 2 minutes apart, and which is 120 seconds, and the contraction's 100 seconds long, then the baby only has 20 seconds to recover. Now, for some clients, the induction doesn't work, so they have to be sectioned. They have to have a cesarean section. Indications for a C-section include dystocia, or an abnormal or difficult labor, repeat C-section, and that's not for everybody, but it is one of the indications. The baby's in a breech presentation. They're butt down, so they aren't able to dilate the cervix. If you have fetal distress or fetal anomalies, if you have a client with active gonorrhea, or they have a herpes infection, remember, we're not going to deliver through the vaginal canal because we don't want to infect the baby. Prolapsed umbilical cord we've talked about. Pregnancy-induced hypertension. If she doesn't deliver through induction, then she'll be delivered through a section, or a placenta previa, or an abruptio placenta. It's very important when a woman undergoes a C-section that you provide emotional support. This client didn't intend to be a surgical patient. They just intended to come in and have a baby. And you have to remember, they are both an OB patient and a surgical patient. It's important that preoperative medication is administered at a lower dose so you don't affect the baby. Monitor for hemorrhage after the delivery, and also provide for comfort measures to control the pain. For example, this patient's a surgical patient. We're still going to encourage them to cough and deep breathe, so you want to make sure and splint the incision while the patient does these exercises. Also very important that you offer the baby to the mother from the as early as possible to promote the parent-child bonding and get these ladies moving as you do for all abdominal surgeries. Let's talk about a precipitous delivery outside of the hospital. What happens when it's that snowstorm or ice storm and your neighbor calls you and says, I think I'm going to have the baby and I can't get to the hospital? So what are you going to do? Well, first and foremost, you are going to stay with your patient. Remember, on NCLEX, we don't ever leave our patient. We always stay with the patient. We are going to prepare a sterile or as clean environment as we possibly can. It's important that during the birth process that you support the infant's head, apply slight pressure to control the delivery because you want to decrease the tearing of maternal tissue. Rotate the baby's head as it emerges. Deliver the trunk and shoulders. Now remember baby care. What's the first thing we're going to do? Well, we're going to try to establish an airway, or we will establish an airway. Dry and place the baby on the mother's abdomen. Wrap the baby in a blanket. Also put the baby to breast immediately because this will help with the contraction of the uterus so that she can pass the placenta, and also will decrease the chances of postpartum hemorrhage. After the baby's born, make sure, and like any postpartum patient, you're going to assess the quantity of bleeding, and also you're going to be assessing the fundal tone. Other childbearing complications that you need to know are symptoms of and care for the maternal hemorrhage, infection, and postpartum depression. Okay, let's talk about postpartum hemorrhage. What are you going to see or feel? First of all, you're going to feel a boggy uterus. Now, for those of you all that haven't actually palpated the postpartum fundus, if a woman's uterus is contracted, it really does feel like your hand, like the ball, your hand is in the abdomen. So when you actually palpate, that's what you feel. If it's boggy, it feels spongy. The client is going to have excessive bleeding. Another symptom you may see is maybe the client has progressed to lochia serosa. It's not the bright red bleeding anymore, it's pink or it's brown. And then the client calls you and says, I started having bright red bleeding again. Now, if the client has a history of lacerations, this could also cause the postpartum hemorrhage. Now, remember, if a client has hemorrhage due to boggy uterus, you're going to feel the boggy uterus and you're going to see the hemorrhage. If a client has lacerations, you're going to palpate the fundus, you're going to feel a contracted fundus, but you're still going to see too much bleeding. So that's your clue that you're dealing with some lacerations. Retained placental fragments will also cause postpartum hemorrhage, as well as an overdistended uterus, the one that's had multiple pregnancies, or a prolonged labor. What are you going to do? Well, first you're always going to assess. You're not going to look at the bleeding and say, I think the fundus must be boggy and massage. You're going to assess first. If you have a spongy uterus, then you're going to massage the uterus until firm. You're going to administer Pitocin, and you're also going to monitor vital signs. Now, another problem that you see in the postpartum period is infection. You will see a temperature of 100.4 or higher, chills, tachycardia, abdominal pain, foul-smelling lochia, localized tenderness, and also altered lab tests such as the cultures and the WBCs. It's very important for postpartum infection, first of all, to prevent it. So you encourage ambulation. You teach your client to change peri-pads frequently and don't reuse soiled pads. If the client goes to the bathroom, they need to change into a clean pad. Good nutrition and fluids. Important to monitor for the signs of infection, the foul-smelling lochia and the elevated temp. If an infection occurs, you will administer antibiotics as prescribed. The last complication that we're going to be talking about is postpartum depression. And you need to distinguish between the baby blues and the postpartum depression. Now, baby blues are caused by fatigue, an alteration in appetite and sleep disturbances, or overstimulation after having the baby. Occurs in about 3 to 7 days after birth, and it's a roller coaster of emotions. Mom is happy, and all of a sudden she's in the corner crying for hours, and she doesn't know what happened. It's just a letdown feeling caused by the fatigue and the sleep disturbances. It's very important that you encourage the client to verbalize feelings. Let them know that this is normal, and this up and down feelings that they're feeling is normal also. Very important to assess for suicide, though, because we want to make sure that we're dealing with baby blues and not postpartum depression. You may encourage your client to join a support group for new mothers. We're now going to talk about childbearing neonatal normal. And the first thing we're going to talk about is what you need to know for the exam. How to perform a newborn assessment is certainly important information, as well as normal findings for the newborn assessment. We're going to begin by talking about normal newborn assessment, the APGAR score. The APGAR is done at age 1 minute and also at 5 minutes. And it's a way of measuring the baby's adaptation to extrauterine life. You measure cardiac tone, respirations, muscle tone, reflexes, and color. So there are 5 categories, and the baby gets either a 0, 1, or 2 for each category. If the child's APGAR score is 7 to 10, that means that this infant is making an excellent adjustment to extrauterine life. If the APGAR score is 4 to 6, that indicates fair adjustment, and 0 to 3 indicates poor adjustment. Now, your babies, a lot of times, it's not very often that they're going to get a 10, because if you look at color, to get a 2, they have to be completely pink. And remember, the babies have acrocyanosis, where their trunks are pink, but their extremities may be blue. So that's why rarely will you see a 10. As far as the normal newborn weight goes, the average weight is from 6 to 9 pounds, which is 2,700 to 4,000 grams. Now, you remember that the baby will lose 5 to 10% of its birth weight in the first few days and regains this in 1 to 2 weeks. So it's very important that you inform the parents about this so they know what to expect. The average length of an infant is 19 to 21 inches. The average head circumference is 13 to 14 inches, and the average chest circumference is 12 to 13 inches. Usually your chest circumference is about a centimeter less than, will be an inch less than the head circumference. And throughout the infant's year, that first year of life, you will continue to measure the head circumference and the chest circumference and compare the two. Baby's temperature range is from a 97.7 to a 99.7 degree range. Heart rate, the baby's heart rate will be about 100 beats per minute when asleep. It will be around 120 to 140 beats per minute when awake, or up to 180 beats per minute when crying. Respirations of the baby averages 30 to 60 breaths per minute, and it's important for you to remember that babies have short periods of apnea. Now, these are short periods, so less than 15 seconds. Any periods of apnea over 15 seconds would be considered abnormal. If one were to take a newborn's blood pressure in either the arm or the calf, the blood pressure would be around 65 over 41. Now, one of the things I want to talk about is temperature with the infants. Remember that you're going to either put them on a radiant warmer, and if you do that, you don't wrap them up because they need their skin exposed to it, or you're going to wrap the baby in a warm blanket, and you may put a cap on the infant so they don't lose body heat. It's important that you check the baby's temperature every 30 minutes until stable, or for 2 hours, and then you'll be checking the baby's body temperature every 8 hours. Now, we talked about the fact that at 8 months it's the height of fear of strangers, and infants go through separation anxiety. And this is really difficult for parents to deal with because the children just cry they're just inconsolable when their parents are not with them. There are stages of separation anxiety. The first is protest, when the child cries and screams and they just can't be comforted. The second stage is despair, and it's almost like a depression. The children are disinterested in food and play, and they just sit around clutching a security object, either the blanket or a favorite stuffed animal. Denial is the third stage of separation anxiety, and in denial, the children are resigned. They're not necessarily happy, but they understand that they've been left alone. And in fact, when a child's in denial, the parents may come back, and this child who just couldn't be comforted when mom walks out of the room, when mom walks back in, it's like, and you expect me to interact with you. So they may ignore the parents. Now, first of all, you need to reassure your parents that separation anxiety, as painful as it is to go through, is normal. It indicates a healthy parent-child relationship because this means that the infant has attached to the parents. Now, as a nurse, you're going to experience the separation anxiety in two ways. One, you're going to be counseling the parents about what to do about it, and secondly, you're going to be the stranger that's approaching this 8-month-old, and all of a sudden they're crying hysterically. So, what do you do when you approach these infants and you are the stranger? First of all, you want to talk softly to the infants. You want to meet them at eye level. So if you walk into an exam room and an 8-month-old is sitting on a parent's lap, you want to stoop down so you're at that same eye level. But you don't want to walk up to them and get this far away from them and stoop down and get in their faces. From a safe distance, you stoop down and you talk softly to them. What you're going to counsel your parents about is to just go through, if they're going to leave a child in a room, because it'll happen, mom or dad will leave this room and go to the next room and the child starts screaming hysterically. They need to continue reassuring the child that they are there by talking to them from a different room. If the parents are at work, maybe they'll want to call and talk with the infant over the phone because then the infant can hear their voice. Or they hand them a favorite blanket or toy. Tell them that they're going to be back after work today and then walk away. But the most important thing you can do is reassure your parents that nothing is wrong, that this is normal. Let's talk about potential problems of infants. Remember, we're into wellness. We're into preventing problems. So we have to alert our parents to the kind of problems that they may deal with. The first is injury. I think it's very important that during the infancy that you observe the parenting skills to make sure that they are doing safe things for their infants. For example, to leave a 2-month-old, to prop them, a 1 or 2-month-old in a pumpkin seat and put them on a table is okay. But when you get to an older child, when they can move around more, they can rock forward and topple right off of the table. The major cause of death during infancy is injury, and aspiration leads the list of injuries. So be very careful about small objects from broken or cracked toys. Inspect your children's toys. If they're broken, if they're cracked, for example, a rattle. A rattle intact is a safe toy for a child. A rattle cracked is not, because then it can break open and those little beads can come out that causes the rattling sound, and the children can aspirate them. Also look at your children's clothing. You don't want button clothing, especially not at the top, because the infant can find this button, pull it off, and then it can be swallowed. They can certainly aspirate on foods, and the foods that are the most common offenders are first and foremost hot dogs. And I do know that hot dogs is tested on the exam. So you're not going to hand the child a whole hot dog, which at 12 months they certainly could manipulate. They've got front teeth. They can they can be biting the hot dog off. But what you want to do if you offer your child a hot dog is break it up into very small, irregular pieces that the child is able to swallow. Certainly hard candy would be another offender. Nuts is also, peanuts would be something that sometimes people offer their children, and they can aspirate. Those peanuts are bad because of allergies. And grapes is another fruit that you would not want to be giving your infants because they can aspirate on it. Another thing that you're going to be evaluating is the infant's car seat. You want to make sure that it's appropriate for the child's height and weight and that the parents are using it properly. As the children get more mobile, older in their infancy, falls is a problem, and also burns. You know, children that go and pull up on a kitchen cabinet and then pull the pan. You know, maybe there's a pan on the stove with the handle out and they pull it off. Another potential problem of infancy that you're going to be evaluating is failure to thrive. Now, failure to thrive is inadequate growth resulting from either the inability to obtain calories or the use of the calories. A child is considered as having failure to thrive if their weight is below the 5th percentile. Now, this can be caused by physical defects such as congenital heart problems, or it can be caused by inadequate parenting, or sometimes the cause is simply unexplained. It's very important as a nurse that you identify not only the child's weight, which is why those milestones of doubling the weight at 5 months and tripling at 12 months is so important, but also you're going to be observing the mother-child interaction or the parent-child interaction. Remember that the goal of care, if you identify that there is a child who has failure to thrive, is to correct the nutritional deficiencies and educate the parents. Now, a third potential problem of childhood or of infancy is developmental delay. And we've certainly talked about the milestones, and you're going to be identifying or assessing your child for these milestones. Okay, let's move on to the toddler and look at toddler growth and development. Now remember the Erickson stage the children are working on at this age, it's autonomy versus shame and doubt. So they're learning to control themselves in the environment around them. A 15-month-old walks alone. So don't use your child when it comes to walking for your milestone. The benchmark for children walking is 15 months. They can throw objects, and boy, can they throw objects. And also they're able to hold a spoon, so they can feed themselves with a spoon. They can also say 4 to 6 words, and they understand simple commands. And a 15-month-old can build a 2-tower block. An 18-month-old, I think the major thing at this age is the anterior fontanelle is closed. Your 18-month-old can climb stairs. They also suck their thumb, which also occurs at earlier ages. Your 18-month-old can build 3 to 4 block towers. They can say 10 words or more. And it's at this age that we have the temper tantrums. They're at their most prevalent. A 24-month-old has a 300-word vocabulary and can obey easy commands. They can go up and down the stairs alone. They can build towers of 6 to 7 blocks. They can turn doorknobs and unscrew lids. So that's very important for your safety on your 24-month-old. And also they have increased independence from their parents. At 30 months, a baby or a toddler can walk on tiptoe. They can stand on 1 foot balanced, and they also have sphincter control for toilet training. At 30 months, the birth weight has quadrupled. They also can state their first and last name. And at 30 months, you can give a child a simple command, put your toy animal over here on this bookshelf, and they're able to do it. Toys for toddlers include cooking utensils, dress-up clothes, rocking horses, finger paints. They also like playing with phonographs or simple CD players. All of their play is imitative at this age, so that's what they're going to be doing with it. If you offer your children dress-up clothes out of your closet, beware of hats, because hats can contain lice. Rocking horses, make sure they're safe or they're low to the ground. For a toddler, you wouldn't get a real high rocking horse. Finger paints, which they love the tactile stimulation of finger painting, make sure that they're in a controlled area. Otherwise, you're going to have finger paints on the walls. So make sure that your toys not only are safe, but the children are in a safe environment to play with them.
Let's go on to a different type of cancer. This is the skin cancer, and there's a couple types of skin cancer. The first one we'll talk about is basal cell carcinoma. And you'll remember with basal cell carcinoma, this is the most common type of skin cancer. What you will see is a very small waxy nodule, and usually appears on sun-exposed skin. So it would be on the face, the arms of patients. And this the nodule crusts and then ulcerates. Again, most common type, and this type of skin cancer rarely metastasizes. Another type of skin cancer is the squamous cell carcinoma. This may metastasize, especially to the blood or lymph. What you will see is a rough, thick, scaly tumor, again, usually seen on the arms or the face. The third type of skin cancer is the most serious or problematic type of skin cancer, and this is malignant melanoma. This is a lethal type of skin cancer. Usually you will see it for patients that are 20 to 45 years old. Patients who are most likely to get this at highest risk are blondes with fair complexions, blue eyes, and either blondes or redheads, freckles. This type of skin cancer is, again, lethal. It easily metastasizes to bone, liver, spleen, the central nervous system, the lungs, or the lymph nodes. What you'll see with this particular type of cancer, there will be a circular lesion of variegated color. And again, the color can be brown or black. It can be mixed with gray or white. It has irregular edges. This is not the very circumscribed mole or freckle that you will see. The variegated color is hugely significant, as are the irregular edges. Again, seen 25 to 45-year-olds, fair complected, and again, it can be and often is lethal. Let's talk about skin cancer and general care for patients with skin cancer. It's a whole lot easier to prevent the development of skin cancer than it is to deal with the outcome. So again, teaching prevention to patients and community groups is very, very important. What you want to do is to avoid exposure to the sun 10 a.m. to 3 p.m. And again, if you've ever done sunbathing, you know those are prime hours to get that super, delicious tan that you've always wanted. But again, you are at highest risk for exposure to skin cancer during that time. You should always wear a sunscreen with an SPF factor, again, a solar protection factor, to block the harmful rays of the sun. And again, this is crucially important for children, because many of the patients that develop malignant melanoma have a serious sunburn while they are children. So they can't necessarily put the sunscreen on themselves and don't know to do it, but parents certainly should be informed how important that is. Patients or people should wear a hat when they're outdoors to protect their face. They should check their skin surfaces monthly. They're looking for moles that are changing color or size, new moles that haven't been there before, and again, especially looking for things that have variegated color and have irregular edges. They use chemotherapy for skin cancers that do metastasize, and again, review your chemotherapeutic agents. They're frequently tested on the NCLEX. We're going to now talk about intracranial tumors, and the type of things that is frequently tested with this topic is the positioning that you should do for patients returning from supratentorial or infratentorial surgery. Let's take a look at what you'll see with intracranial tumors. Again, the signs and the symptoms depend on the location of the tumor, but there may be motor deficits, meaning inability to move. There may be hearing or visual disturbances, especially if the occipital area is involved. There will be dizziness or perhaps paresthesias if the cerebellum area has the tumor. There can be seizures. Again, that you will see if the motor cortex is involved. There may be personality disturbances, and again, that's usually seen with tumors of the frontal lobe. There can be changes in level of consciousness, and again, that's for any of the different types of intracranial tumors. Now remember that the tumors, intracranial tumors, are classified according to location. You have supratentorial tumors. These are tumors usually within the cerebral hemisphere. Usually when surgery is done on these, the incision is behind the hairline. So I always think of supra is the top. It's the super, so that's in the top area. You also have infratentorial tumors, and the type of surgery they do, usually the incision is at the nape of the neck, around the occipital lobe. And again, this is surgery within the brain stem and cerebellum. So these are lower, if you will, or inferior type of tumors. That helps me to remember it. The type, we talked about the signs and symptoms. Let's talk about the type of nursing care you will do for patients being treated for intracranial tumors. Treatment for intracranial tumors is surgery. And let's talk a little bit about the pre- and post-op care that you'll provide for these patients. Well, first of all, preoperatively, you want to do a detailed neurological assessment because you want to establish very, very accurate baseline data, because you'll be using that data after surgery to compare and see how the patient is doing. Again, you want to prep the site, and usually the patient's head will be shaved. And again, you need to deal with the body image changes that go with that. Let's talk about post-op care. Well, first and foremost, again, with this patient, as with any surgical patient, you want to maintain a patent airway. The patient's head will be elevated 30 to 45 degrees if they have had the supratentorial surgery. If they have had infratentorial surgery, you will position them flat and lateral. Again, you want to monitor vital signs and neurological signs. You'll be doing or frequently monitoring the Glasgow Coma Scale. Medications used for these patients are corticosteroids because of their anti-inflammatory actions. We use osmotic diuretics to prevent the increase in intracranial pressure. They will use analgesics, and they do not use narcotics because they can mask the signs of increased intracranial pressure. Anticonvulsants are used because of the danger or increased risk of seizures. Antibiotics are used to prevent the development of infection. Antipyretics are used, again, because thermoregulation can be a problem. Antiemetics because nausea and vomiting is a problem. And in some cases, hormone replacements are used for these patients. The type of, you want to observe for complications, and the type of complications you're looking for, the most frequently ones seen are respiratory complications and increased intracranial pressure, the hyperthermia, meningitis, and wound infection. Again, we want to monitor for those and make sure that the patient remains stable. We're going to now talk about pancreatic tumors. And remember, tumors can arise in any part of the pancreas, but most, it can be the head or the tail, and each type of pancreatic cancer has its own clinical signs and symptoms. But what most oftentimes is seen is a weight loss. The patient complains of vague, very upper or middle abdominal discomfort. They have hyperglycemia. They may experience jaundice or the yellow sclera. They get clay-colored stools, meaning they get light in color, and dark urine. Now, the type of implementation you'll do for patients with pancreatic tumors, if they're being treated medically, they will be put on a high-calorie, bland, low-fat diet. They will have frequent feedings. These patients should avoid the use of alcohol. They may be given anticholinergics to decrease secretions, and they may be put on anti-neoplastic chemotherapy. And again, the chemotherapy and the anticholinergics are done. In some cases, surgery is done, and what they do is the Whipple procedure, where they remove the head of the pancreas and the distal portion of the common bile duct, the duodenum, and part of the stomach. Let's talk about post-op care after the Whipple procedure. You want to monitor the patient for the development of peritonitis and intestinal obstruction. You want to monitor for hypotension. If patients have this type of surgery, they will need administration of pancreatic enzymes. And remember, they're given before meals, not after meals. And again, you want to monitor for the development of diabetes. The medications, again, patients can undergo chemotherapy for pancreatic tumors, and many times they will give them anticholinergics. Let's go on to our last topic of this particular session, and that's carcinoma of the larynx. What you will see many times, there will be hoarseness, dysphagia or difficulty swallowing. The patient may have foul breath. They may have pain that radiates to the ears. They might be dyspneic or have difficulty breathing. Their lymph nodes will be enlarged, and they may have hemoptysis, which is bloody sputum. The usual causes of carcinoma of the larynx are cigarette smoking and the use of alcohol. It also is many times seen with straining of the vocal cords. Let's take a look at the implementation. Treatment for carcinoma of the larynx is surgery. Before surgery, it's very important to talk with the patient and let them know what the surgery entails. Usually what they will do is they will take out the larynx or the voice box, and the patient will be unable to speak after the surgery. So before the surgery, you want to explain all this, and you want to figure out what you're going to do for communication, how to communicate with the patient after surgery. Okay, patient goes to surgery, comes back. We will put them in a semi-Fowler's position. You will provide stoma care because they will have tracheostomy in place, and you need to give good care for that. We talk about that with our reduction of risk unit, and please do review that. Patients need frequent suctioning because, again, remember, this is their airway, and we need to ensure that it remains patent. Patients many times are given nasogastric feedings after this type of surgery, and one of the things that you do differently with this patient than most of the other patients you give NG tube feedings with is you will put a little bit of color, and usually they use blue or green, into the nasogastric feedings to make sure if there's a problem later or when you're suctioning, if you begin in your suctioning of the trach to see red or blue colored secretions, you know that there's a problem. You would never use red food color because then that would be indistinguishable between the red food color and blood. But they do check or add food coloring. They're checking for aspiration when the patient is suctioned. You would teach the patient esophageal speech or the use of an artificial larynx because these are the methods they use after surgery once they've gotten out of the acute phase to communicate. In one, they swallow air and then kind of regurgitate or eructate it up, moving their lips as they talk, and that's esophageal speech. An artificial larynx is a mechanical device that's held against the neck, and as the person moves their mouth and forms words, it changes the tone of the vibration of the artificial larynx. Well, this concludes our discussion of physiological adaptation. Let's talk about some other rhythm disturbances, and we're going to talk about atrial dysrhythmias. Remember, atrial dysrhythmias are abnormal electrical activity that results in stimulation outside of the SA node, but within the atria. Again, remember, it's outside the SA node. We talked about those problems already. It's in the atria, but outside of the SA node. First of one you will see is PACs, or premature atrial contractions. These are where you have an episodic foci, or an area that will fire prematurely. And remember, any cell within the heart has the ability to initiate an impulse. So this impulse is coming from someplace other than the SA node within the atria. And the trouble with PACs is it may be an early sign of an abnormal electrical problem. So while they may not cause a lot of symptoms, it is something that should be investigated thoroughly. Another atrial dysrhythmia is PAT, or paroxysmal atrial tachycardia. This is where you have a sustained tachycardic state. You have rapid rhythmic discharge of impulses from some place within the atria outside of the SA node. If this is prolonged, and if this happens for a period of time, the problem with PAT is it decreases the amount of time that the ventricles can fill. So if they can't fill fully, then when they're contract, they don't get a whole load sent out either to the lungs or to the systemic circulation. So it decreases cardiac output, and that really is the problem. It's not that we're looking for a nice rhythm strip. It's that if something is messed up and this contracts and this doesn't contract, or it's only half full, then the output is decreased, and that's what the problem is. And you will get PAT from ischemia of the muscle in the atria. You can get it from rheumatic heart disease. You can get it from an MI, and sometimes anxiety will cause PAT. Another type of atrial dysrhythmia is atrial flutter. This is where you have multiple P waves sending out, and it can either, the pulse may be regular or irregular. And they arise again from a focus within the atria outside of the SA node. And that focus can fire as many as 250 to 400 times. But what happens is you might say, oh my gosh, then, the heart must be just going crazy. But while this focus is firing that many times, the AV node will block many of the impulses coming to it. It just blocks them, totally ignores them. And that protects the ventricles from reacting to every impulse that comes down to it. Some of the patients are aware of atrial flutter, and they'll do it, they get kind of palpitations or they feel faint. Other patients do not. Causes of atrial flutter can be stress, can be hypoxia, and things such as hypertension, and it is caused by some medications. The last atrial dysrhythmia we're going to talk about is atrial fibrillation. This is the most common type of atrial dysrhythmia. And what happens is there are several foci within the atria that are sending out impulses. And what you will see with someone with atrial fib is a grossly irregular pulse. Usually what they'll do is they get confused because, again, it interferes with cardiac output, or they may have syncope, fainting, or they may get dizzy. The causes of atrial fibrillation can be chronic lung disease, can be heart failure, and can be rheumatic heart disease. Let's go on and talk about the ventricular dysrhythmias. And just kind of a general thing, your atrial dysrhythmias are not good, but they're not as bad as the ventricular dysrhythmias. Remember, ventricular dysrhythmias happen when one or more foci within the ventricles send out an impulse and cause the ventricles to contract. Our first ventricular dysrhythmia is PVCs, which are premature ventricular contractions. Here we have one or more foci sending out a stimuli. The problem with this is because we want a rhythmic, atria ventricles, if the ventricles are reacting to other stimulus not coming through the normal pathway from the SA node to the AV node, what it does is it decreases the efficiency of the heart pumping action, so it decreases cardiac output. What patients may complain of is palpitations or kind of a lump in their chest or in their throat. The causes of PVCs are ischemia, can be caused by myocardial infarction, electrolyte imbalance sometimes will cause it, stimulants such as nicotine, caffeine, alcohol may cause it, medications such as digoxin may cause it. So again, that's something that it can be serious because of the effect it has on cardiac output. The second type of ventricular dysrhythmia is ventricular tachycardia. This is when you have 3 or more PVCs occurring in a row. And this tells you that the myocardium is very irritable. And that doesn't mean cranky. That means that, remember, any cell within the myocardium can send out a stimulus for a contraction. And if the muscle itself is irritable, the cells are more likely to send out a stimulus for a contraction. And again, if you have 3 PVCs in a row, the biggest thing that happens is that you don't have rhythmic contraction of the atrials and the ventricles, and that decreases cardiac output. So with ventricular tachycardia, you can see dizziness, you can see faintness, and occasionally the patient will collapse. Now, the most serious type of rhythm disturbance we're going to talk about is the one that we're going to talk about now, and that's ventricular fibrillation, When you have ventricular fibrillation, there is almost no connection between what the atria are doing and the ventricles are doing. And the ventricles are not contracting rhythmically. The muscle is just kind of fibrillating, just kind of quivering. And what happens is it decreases cardiac output almost to the nil and none stage. So your cardiac output will precipitously fall. If this is not interfered with and fixed very shortly, death will ensue, because of the fact that there is limited, if at all, cardiac output. This can be caused by an MI, can be caused by hypertension, can be caused by arteriosclerotic heart disease, or hypoxia. Now, okay, what do I do? How can I restore blood flow? Well, in the short term, you will start CPR, because that you will then compress the heart with your cardiac compressions to get flow through the heart, and you'll be doing the breathing to, again, oxygenate the blood. And then the other thing that we will do for this is we will do defibrillation to reestablish the normal pacemaker of the heart. Okay, and we'll talk about defibrillation in just a few minutes. Let's finish with the type of rhythm disturbances that you can see. One of the other rhythm disturbances is called heart block. And with heart block, what you have is you have a delay in the conduction of impulses within the atrial ventricular system. Remember, usually it's SA node to AV node, and then the PR interval, it goes from one to the other, to the bundle of His, down the bundle of branches, and out through the Purkinje fibers. Well, if that conduction is interfered with and slowed, you'll end up with heart block. And let's talk about the different types of heart block. The first, and again, we're going to go from not good, but not horrible, more serious, and most severe. Bundle branch block can be of the right or left bundle branches, and what they do is the area is blocked. It's kind of like they've shut the road down. So what happens is the impulse has to go around it, and that causes it to be slowed. So that's not good. It can be caused by MIs. You'll see it sometimes with digitalis toxicity. And again, your left bundle branch block is more serious than your right bundle branch block, because your left side of the heart is responsible for injecting blood or sending blood to systemic circulation. Now, the next more serious heart block is first-degree heart block. What happens in this particular case is every impulse from the SA node gets to the AV node and goes on, but at a slower rate. It's kind of held there for a while, and then he says, okay, I guess I'll send it on now. So what you'll see when you're looking at the EKG strip is the PR interval is prolonged. And again, when we talk about first, second degree heart block and third or complete heart block, it has to do with the degree of delay in the conduction of the cardiac impulse. Okay, second degree heart block, not only does the AV node delay the impulses, but it decides not to send some of them on. So not every impulse that starts at the SA node gets to the AV node, but the AV node says, you go, you don't, you can go, you have to wait, that type of thing. So not every impulse gets through the system. Now, the causes of this can be infection, can be caused by dig toxicity, can be caused by coronary artery disease. And what you'll see with second-degree heart block is there may be a slow pulse rate, the patient may have decreased blood pressure. Now, the most serious kind of heart block is complete heart block. In this particular case, impulses from the SA node get to the AV node, but the AV junction blocks all the impulses. It says, I'm not sending anybody through. Everyone's on their own. And what happens is the atria beat at their own rate because of the stimulus from the SA node, and the ventricles beat at their own rate, but their rate is much slower than what happens in the atria. Left to their own devices, the ventricles will beat about 20 to 40 beats per minute. They're slow workers, let's say, so they don't work real hard. They'll beat, but they'll beat slowly. And the key to this is that because it beats so slowly, again, a pulse rate of 20 to 40 doesn't provide for a lot of cardiac output. So that really is the problem with complete heart block, where the atria and the ventricles are kind of doing their own thing. They're not operating in conjunction with each other. This one's doing his thing, and this one, when it feels like it, it does its own thing. So that's not good. And again, complete heart block, if not treated, can lead to death. Some of the symptoms you'll see are palpitation, dizziness, syncope, and some of the causes are congenital defects. It can be caused again by a myocardial infarction. Let's take a look at some or talk about some of the diagnostic tests that happen or we use with rhythm disturbances. The first one is an EKG. And I'm going to go ahead to the next slide and show you this is an EKG. And again, remember what the pieces are and what they represent. Because again, you're not going to have to be a coronary care nurse on the NCLEX exam, but you're going to have to be able to both calculate the pulse rate and be able to identify normal sinus rhythm in some of the major, you should be able to identify ventricular fibrillation and things such as a PVC because they are apparently abnormal. Okay, the first bump on this slide indicates the P wave. This is the atrial activity. This is when the atria contract. Between the first bump and the tall mountain spike is the PR interval, and that's when the impulse goes from the SA node down to the AV node. The QRS complex, which is the tall inverted V in this particular situation, that represents ventricular activity. That's when the ventricles contract. After that, the next slightly higher wave than the P wave, kind of rounded U, this is the T wave. And this indicates repolarization of the ventricles. And many times when you have electrical problems in the heart, it will be identified or you'll see it because of changes in the T wave. The very last hump, which is kind of just a small rise in the road here, is the U wave. And some patients may have this, some patients may not. So this is what a normal EKG looks like. Okay, let's go back. So EKG is something that you should know about and know how to identify normal versus abnormal. The second type of diagnostic test they use are arterial blood gases, or ABGs, and we talk about those in our reduction of risk area. Remember, they're used to evaluate clients that are on mechanical ventilation or that have cardiovascular disease. It tells you about tissue oxygenation, carbon dioxide removal, and acid-base balance. The next type of diagnostic testing we're going to talk about is a Holter monitor. A Holter monitor is a 24-hour continuous EKG reading. So what happens is the patient is hooked up with leads, and for 24 hours their EKG is monitored. And that's important, but what's equally important is during that 24 hours the patient keeps a diary of exactly what they do. They put the time, they put what they do, and if they feel anything other than normal, they'll write that down. So if at 9 o'clock I'm going to walk the dog at a brisk pace for 4 blocks, I'll write that down. And if during my walk I begin to get a few palpitations, I'm going to write that down. Because what they do is then they evaluate the 24-hour strip in conjunction with activity. It tells you whether or not the heart is able to keep up with the demands placed on it by normal activity by that patient. The next diagnostic test is a cardiac catheterization. This is the introduction of a catheter into the heart that they're looking for function and structure and how it works. And we talk about cardiac catheterization in the reduction of risk area. The next type of diagnostic testing is an echocardiogram. An echocardiogram is a non-invasive test. It's where they use sound waves to examine cardiac structures. So they use sound waves and they can see how the heart is doing. The last type of diagnostic testing for rhythm disturbances is the stress test. What they do in this case is they will put the patient on a treadmill, or they'll pedal a stationary bicycle, or climb a set of stairs. And while they're doing this type of activity, they're hooked up to an EKG machine, both before, during, and after the activity. And what they're trying to do is to find out what level of demand on the heart will cause the patient or the heart to begin to decompensate and begin not to do what it needs to provide enough oxygenation for the body. It kind of shows that at resting the patient is fine, but if he walks on the treadmill very, very fast, you begin to show signs of cardiac ischemia. And again, that will be noted on the EKG tracing. Let's talk about a lumbar puncture, an LP. A lumbar puncture is insertion of a needle into the subarachnoid space to obtain specimens, to relieve pressure, or to inject dye or medications. The type of things you need to know and may be tested on the NCLEX are: how do you get the patient ready for an LP? What is the procedure? What is the care after the procedure? And what complications are you looking to prevent? So let's talk about getting the patient ready for a lumbar puncture. First of all, you want to position in the lateral recumbent fetal position at the edge of the bed. So they're on their side in a fetal position at the edge of the bed so the physician can work there. What the physician does is he inserts a needle between the third and fourth, or the fourth and fifth lumbar vertebrae. So, and they take specimens, or they inject things, or they do whatever it is that they're looking to do. After the procedure is over, after the LP has been completed, what you want to do, and again this is very important, is you want to do a neurological assessment every 15 to 30 minutes to make sure that the patient is stable. The patient will be positioned in the prone position, meaning on their face, for 2 to 3 hours, and fluids are encouraged. Now, some patients experience a headache after a lumbar puncture is done. And usually if they have a headache after this, it's worse when they're sitting or standing, and it gets better if they're flat in bed. And the reason for a headache following a lumbar puncture is that there is leakage of the cerebrospinal fluid at the puncture site. So the fluid kind of leaks there, and what happens is then the amount of cerebrospinal fluid that bathes the brain or supplies the brain is less than it should be, and the brain is unstabilized. So if the physician takes more than 20 milliliters of solution, more than that is removed during the LP, you will position the patient prone for 2 hours, then sideline for 2 to 3 hours, then supine or prone for 6 hours. Again, this is done to prevent the headache that may occur after the procedure. If the patient experiences a headache, it is managed by bed rest, analgesics, and hydration. And again, you want to check the site for drainage. The next diagnostic procedure we're going to talk about is an electroencephalogram, or EEG. This records the electrical activity of the brain and is used to diagnose seizure disorders, to evaluate patients in coma, patients with organic brain syndrome, and is used to determine brain death. What they do for an EEG is electrodes are applied to the scalp to record the electrical activity of the brain. To get the patient ready for an EEG, tranquilizers and stimulant medications are withheld for 24 to 48 hours before the procedure is performed. Stimulants such as caffeine, chocolate, cola, cigarettes are withheld for 24 hours before the test is done. During the test, the patient, if they're able and awake, may be asked to hyperventilate. Now, meals are not withheld during the test because if the patient becomes hypoglycemic, it might change the outcome or the brain wave pattern. So meals are administered regularly or as needed before the test is done. But the patient may be kept awake the night before the test because in some of the tests, they have the patient sleep and they need to be tired enough that they can sleep during the test. When they start the test, they will get a baseline reading when the patient, with the patient, when they lie flat with their eyes closed. Then they will experience or show the patient flashing lights or encourage them, ask them to hyperventilate for 3 to 4 minutes. And what they're looking for is they're looking to establish seizure potentials or what would cause the patient to have seizures. Other things with an EEG, after the test, you want to help the patient remove the paste from their hair where the electrodes were applied. Any medications that were withheld before the test should be administered after the test. And you do want to observe the patient for seizure activity. Again, many patients who undergo an EEG have seizure problems, so you want to monitor for that after the procedure is over. Let's talk about a CT scan. You'll remember that a CT is a narrow X-ray beam that is used to provide images of structures. It detects hemorrhage, infarctions, abscesses, and tumors. Getting someone ready for a CT scan, you need to find out if they're going to use dye for the procedure, because because if dye is going to be used, you need to let the patient know before they go to the test that when the dye is injected, they may feel a feeling of warmth, they may become flushed, and they may experience the metallic taste when the dye is injected. After the test is over, after the CT scan, you want to assess for any allergic reaction to the dye and encourage the patient to have fluids, again to 3,000 cc's a day. Another test that's done, but not as often as it used to be because of all the improvement of other diagnostic tests, but that's the myelogram. A myelogram is an X-ray of the subarachnoid space taken after the injection of dye through a lumbar puncture. Getting someone ready for a myelogram, they are NPO for 4 to 6 hours before the test. Phenothiazides, central nervous system depressants, and stimulants are withheld before the test. And you need to let the patient know that during the test the table is going to be moved so they know what to expect. After the myelogram is over, you want to do a neuro assessment every 2 to 4 hours to make sure that there's no changes. When the patient comes back, you will position them with their head raised 30 to 45 degrees for the first 3 hours after the procedure. And again, you want to encourage fluids. You also want to check the patient's ability to void. And the untoward effects that may occur after a myelogram are headache, fever, stiff neck, and photophobia. Let's talk about a liver biopsy. A liver biopsy is removal of a tissue sample by needle aspiration. What you need to know and what's frequently tested is, how do you get a patient ready for a liver biopsy? How is the procedure performed? What's the care after the procedure? And what complications are you looking to avoid? So let's talk about getting someone ready for a liver biopsy. Many patients with liver disease that are going to have a liver biopsy, they may need to have vitamin K administered IM before the procedure is done because of the danger of hemorrhage. Remember, the liver is a highly vascular organ, so they may get aquamaphytin or vitamin K IM before the procedure. The patient's NPO for about 6 hours before the procedure is done. They're given a sedative, and then for the procedure they are positioned supine lateral with their arms elevated. They're asked to hold their breath 5 to 10 seconds when the needle is inserted. After the test is over, you want to position the patient on their right side for 2 to 3 hours with a pillow under the costal margin. This is again to put pressure on the site so that hemorrhage does not occur. And the patient should stay immobile. You'll check vital signs. You want to check clotting time and platelets and hematocrit. And any severe abdominal pain should be immediately reported. Again, when they come back, you're going to check pulse and blood pressure, usually every 10 to 15 minutes for an hour, and then every half hour for the next 2 hours or so until the patient is stable. The complications are bleeding, and again, that's a very real complication you're looking to prevent, or bile peritonitis. And when the patient is discharged after a liver biopsy, they need to know to avoid heavy lifting or straining for at least 1 week after the procedure. Let's talk about a stomach or esophagus endoscopy. Remember, this type of endoscopy is a visualization of the esophagus and stomach using a lighted, flexible fiber optic tube. Getting a person ready for a stomach or esophagus endoscopy, they should be NPO for 8 hours. And they use a local anesthetic, so you need to let the patient know that their throat area will be numb. After the procedure is over, the patient will remain NPO until the gag reflex returns. What you're doing after the procedure is you'll be checking for vomiting of blood and checking for respiratory distress, because those are the complications you want to make sure and avoid. And let the patient know that they're going to have a sore throat for probably the first 3 to 4 days. It's not unusual, but then it should subside. The next diagnostic test we're going to talk about is a sigmoidoscopy. A sigmoidoscopy is where they use a lighted endoscope to visualize the sigmoid colon, the rectum, and the anal canal. Getting someone ready for a sigmoidoscopy, they will have or be ordered a laxative the night before the exam and have enemas or a suppository the morning of the exam. They'll also be NPO from midnight of the day before the exam. After the test is over, you will allow the patient to rest. You want to monitor for hemorrhage because that's one of the complications you're hoping to prevent. And you want to encourage fluids for the patient, again, 2,000-3,000 cc's. Let's talk about a colonoscopy. A colonoscopy is use of an endoscope to directly visualize the colon. A colonoscopy can be used as a diagnostic aid. It can be used to remove foreign bodies, polyps, or it can be used to obtain a tissue sample or a biopsy. What you do to get someone ready for a colonoscopy is they will be on a clear liquid diet for 24 to 72 hours before the test is performed. They will receive a cathartic each evening for 2 nights prior to the day of the test. They will have an enema the morning of the exam, so that's one procedure or prep. Or they can be on a clear liquid diet from noon the day before the test and take a Go Lightly, or what's considered or called Go Lightly solution, which is a lavage solution the day before the test. And this is a solution used to cleanse the bowel. Patients that are receiving anticoagulant therapy, it is contraindicated for them to have a colonoscopy due to the risk of bleeding. So you'd want to make sure and check the patient's history before you worked with them for the preparation. After the colonoscopy is over, the complications you're looking for are hemorrhage and perforation of the intestine. So you will check for hemorrhage and you will check for respiratory distress. Often the patient will have follow-up x-rays and they can resume their normal diet. Let's talk about a gastric aspirate. Gastric aspirate is where they aspirate gastric contents. What they're looking for is blood, abnormal bacteria, and abnormal pH or malignant cells. Getting a person ready for a gastric aspirate, they will be NPO for 8 to 12 hours before the procedure is done. What they do is they pass a tube and they aspirate stomach contents through the NG tube. Histamine may be given to the patient because that stimulates the secretion of gastric secretions. And then they will collect samples every 15 minutes for about an hour to see what response the gastric area did. And the results are checked for blood and the pH is measured. After a gastric aspirate, there are just comfort measures for the patient and you should encourage fluids. An upper GI series is also known as a barium swallow. This is the ingestion of barium to evaluate the esophagus, the stomach, and the rate of passage into the small bowel. Preparation for this is they will be on a low residue diet for 1 to 2 days. They'll be on a clear liquid diet the day before. They'll be NPO at midnight. They'll have enemas until clear the morning of the test. And you need to let the patient know that after the barium swallow, their stool will be light colored because of the presence of barium. It's not unusual. In fact, it's good. You want the barium to pass. Now, if a patient's going to have both a barium enema and an upper GI series, you want to make sure that the barium enema is done before the upper GI series. Okay, after an upper GI series, what you will do for the patient is you want to encourage fluids. Laxatives are given to prevent constipation because you want the barium to be expelled. Otherwise, it turns into something similar to concrete. So you do expect the stool to be white from the barium, and you want the patient to pass all the barium. So constipation is not a complication. Let's talk about a barium enema or a lower GI series. Installation of barium into the colon using the rectum or via the rectum. And what they're looking for are tumors, polyps, strictures, ulceration, and obstruction. To get the patient ready, they will be put on a liquid diet and a laxative the night before the exam. They'll have enemas the morning of the exam. X-rays are taken during the procedure to find out what's going on. After the test is over, cleansing enemas are used to remove the barium so it doesn't become impacted. And again, X-rays are repeated after the barium is expelled to see, what, if anything, is left. Let's talk about a paracentesis. A paracentesis is a needle aspiration of fluid in the abdominal cavity. It's used for diagnosis, or in some cases it's used for treatment. With paracentesis, the type of things that are frequently tested on the exam are, how do you get the patient ready? What is the preparation? What is the procedure? The care after the procedure, and what complications may occur. So let's talk about getting someone ready for a paracentesis. Preparation for a paracentesis is you will position the patient in a semi-Fowler's position or sitting upright at the edge of the bed. The patient will be instructed to empty their bladder so there's no danger or risk of bladder perforation. Then the needle is inserted and the fluid is removed. After the test is over, you want to check vital signs. Again, you're removing fluid and you want to make sure that there's not hypotension due to fluid shifts. You would report any fever, if the patient develops a fever, or any abdominal pain because of the danger of infection, and you want to observe for shock, because that's one of the major complications after a paracentesis. Let's talk about a laparoscopy. Laparoscopy is a visualization of the pelvic cavity through the insertion of an endoscope, and there's an incision made beneath the umbilicus, and the endoscope is inserted to view the structures. You can use a laparoscopy to diagnose a problem or to treat a problem. They use a laparoscopy for a tubal sterilization. They use it for an ovarian biopsy, and they use it if the patient has adhesions to lice or to cut the adhesions. Getting someone ready for a laparoscopy. In preparing them, you need to let them know that a general anesthetic is usually used, and a Foley catheter or indwelling catheter is inserted. What they do for a laparoscopy is carbon dioxide is introduced. What it does is it's insufflated and it separates the intestines from the other pelvic organs so they can work in the area without having everything all pushed together. After the test is over, after the laparoscopy, the patient is allowed to be out of bed after the procedure and they resume their regular diet. Let's talk about a cystoscopy. Cystoscopy is a direct visualization of the bladder and urethra using an endoscope. Getting someone ready for a cystoscopy. They will do the bowel preparation like we've talked about before with the laxatives and enemas. Fluids are forced because, again, you need to have fluid in the area so you can see things. The patient will be NPO before the test is actually performed. Now, after the test, you want to monitor the character and volume of urine. There might be some hematuria, there might not be. But what you're looking for is abdominal distension, urinary frequency, and fever, which would indicate infection. The urine often is pink tinged because of the cystoscopy, and often they will order antimicrobial prophylaxis. That's antibiotics used prophylactically to prevent the development of infection. After cystoscopy, moist heat can be used or sitz baths can be used for comfort. Let's talk about an IVP or an intravenous pylogram. This is X-ray visualization of the kidneys, ureters, and bladder using dye. What you need to know and what's frequently tested is the preparation, the procedure, what goes on during it, care after the procedure, and the complications. So to get someone ready for an IVP, you want to do bowel preparation, and we talked about that. That's the laxatives and enemas before the procedure is done. The patient is NPO at midnight. Before they ever are signed up for this, you need to check allergies, and the allergies you're looking for are shellfish, iodine, chocolate, eggs, and milk. Because of the dye that's used during an IVP, if they have these type of allergies, they are much more likely to develop an allergic response to the dye used for the procedure. You need to let the patient know that they may experience a burning sensation or may taste a salty taste when the dye is injected. And then during the procedure, during the IVP, x-rays are taken at intervals. After the IVP is over, you will check for a delayed reaction to the dye and the type of things you're looking for if the patient becomes dyspneic or difficulty breathing, if they wheeze, if there's edema, or if there's itching. This would indicate an allergic reaction to the dye and should be considered a medical emergency. Let's talk about a kidney biopsy. With a kidney biopsy, tissue is obtained by needle aspiration. Getting someone ready for a kidney biopsy. They will be NPO for 6 to 8 hours before the procedure. X-rays are taken before the procedure to locate the area where the biopsy is actually going to take place. And usually the skin is marked on the outside of the body at the lower pole of the kidney because that's where the biopsy is performed.
To do the biopsy, the patient is positioned prone, meaning on their face, and bent at the diaphragm, and they're asked to hold their breath during the insertion of the needle. Now, after the test, again, one of the dangers you're looking for is hemorrhage. So what you need to do is make sure that pressure is applied to the site for 20 minutes. The patient is positioned prone, and a pressure dressing is applied. You're going to be checking vital signs very frequently, every 5 to 15 minutes for the first hour after the procedure. When the patient comes back to his room, he will be flat in bed on bed rest for 6 to 8 hours. And you're looking for hematuria or blood in the urine, and you're looking for bleeding at the site of the insertion. You'll also want to encourage fluids after this to 3,000 cc's per day. The next test or diagnostic test we're going to talk about is a Schilling's test. This is a test used to diagnose vitamin B12 deficiency. To get someone ready for this test, what you do is you give an oral dose of radioactive vitamin B12. A few hours later, you give a dose of non-radioactive vitamin B12. Because what you're doing is you give them the radioactive dose, you wait a few hours, you give the non-radioactive dose, and then the urine is going to be measured for radioactivity. You're looking to see how much radioactivity passed through the patient and is excreted in the urine. The normal amount excreted in 24 hours is greater than 10% of the dose that's given. Because what this means is if a lower amount, if just a little bit comes out in the urine, that means the patient has pernicious anemia, because it means that that first dose, that radioactive dose, was absorbed by the body. But a normal person without pernicious anemia, that first dose, most of it would just pass through the body because the body doesn't need it. It can absorb it regular ways, and it absorbs it again. The second dose will be absorbed and no problem. So a diagnosis of pernicious anemia with the Schilling's test will take place if a low amount of radioactive B12 is released after the test is done. And the reason it's a small amount is the body absorbed it because it needed it. That concludes our discussion of diagnostic tests. We're going to now talk about therapeutic procedures.